Welcome to this edition of Milestones in Oncology, an educational program developed by the Society for Translational Oncology. With the development of new targeted drugs that exploit differences in gene expression between malignant and normal cells, conventional treatment of non-small cell lung cancer is undergoing a renaissance. To explore the impacts of contemporary drugs on lung cancer and to describe some of their side effects in patients, we are pleased to introduce two innovators who are at the leading edge of this milestone in oncology. Lung cancer at the advent of targeted therapy is the topic that our interlocutor, Dr. Bruce Chabner, will discuss with Dr. Tom Lynch, a clinical investigator whose research is lengthening high-quality life for lung cancer patients. We are doubly fortunate to also welcome Dr. Mario Lacouture, whose research focuses on the dermatological disorders that arise in cancer patients as a consequence of some therapy. We hope that this session proves of value to you, and through you, to your patients. I give you to Dr. Bruce Chabner.
So let's meet our panelists. First, I'd like to introduce Dr. Lynch. Tom, tell us a little bit about yourself and how you got into the field of lung cancer.
So, Bruce, I went to medical school at Yale, and after that went to the Mass General for internal medicine training, and then did my oncology training at the Dana-Farber. And lung cancer was an area that I was attracted to primarily because at the time I was choosing a specialty in oncology. There were very few people working in lung cancer. It was a disease where most oncologists felt you couldn't really treat it. People didn't do very well with it, and yet it still was, even in the late 80s, it still was the leading cause of cancer death in the United States among men, and during the course of my career, it's become the leading cause of cancer death among men and women in the U.S. So I ended up doing lung cancer primarily because there was an extraordinary need for new ideas in lung cancer.
Yes, yes. Now, Mario, you're a more recent entrant into the field of lung cancer treatment. Tell us a bit about your background and how you got involved with the EGFR receptor inhibitors.
So, Bruce, my background is in dermatology residency at the University of Chicago. I did my internship at the Cleveland Clinic and also a research fellowship at Brigham and Women's Hospital in immunology. And during my residency at University of Chicago, I realized how the remarkable contributions made by oncologists, such as Dr. Lynch, could be enhanced by optimizing the use of these drugs by managing these side effects that occur so frequently in these patients. So since then, I became interested in treating these patients' side effects involving the skin so that their quality of life and their therapy could be consistent.
Terrific. So let's get back to the story now of the EGFR inhibitors. Tom, you were very early involved in the development of these drugs, and when they came into the clinic, the thought was, as I recall, that the EGFR inhibitors such as Iressa from AstraZeneca and Tarceva from OSI would be active perhaps against the broad spectrum of tumors that express EGFR. And as we've now learned, the story is a little more complicated than that. But tell us about some of the early things that were observed in these trials.
Well, some of the interesting points were that we thought initially that these drugs might work very well against squamous cell carcinomas since they have an abundance of EGFR expression. And initially we thought that these drugs would target EGFR expressing cells, so cells that you could pick up by immunohistochemistry as being positive for EGFR. So many of the early trials were using EGFR selection by immunohistochemistry as a basis for determining whether or not these drugs worked.
Now, what percentage of patients with lung cancer express EGFR?
Somewhere between 85% and 90%, depending upon the series that you look at.
And is it pretty much universal across adenocarcinomas and squamous carcinomas?
Not in small cell.
Okay, so what did the early trials show?
So the early trials showed that when you use a drug like Iressa was the first one we used, although Tarceva was in development at about the same time, we saw some patients would have a modest response to these drugs, perhaps a response short of a partial response by RECIST criteria. But what was striking to us was that there was a population of patients that had remarkable responses to the EGFR inhibitors. And we saw initially some responses. I remember talking to Mark Chris from Memorial Sloan Kettering, who did one of the first phase 1 trials of ERISA. And he explained, talked to me about his experience. It was very similar to what I was seeing, where there were some patients where the degree of tumor response was greater than anything we've ever seen with chemotherapy in lung cancer. Patients would have lymphoma-like responses.
Can you tell us about some examples of patients and what's happened to those patients?
Well, a good example of one of the patients actually that we treated, who was one of the reasons we discovered the EGFR mutations were important, is a woman who I treated back in the early part of 2001, 2002, a woman who presented, a non-smoking woman. At that time, she was in her mid-40s, and she presented with a right upper lobe mass, a solitary brain lesion, and disease in the mediastinum. We gave her chemotherapy, radiation, very aggressively treated her cancer, yet despite giving her our best chemotherapy and best radiation, she progressed with about 8 lesions in her liver. So at the time, we had opened the ERISA Expanded Access trial. We had already finished the phase 2 trials of ERISA in second line, and we had an Expanded Access trial which allowed us to put patients on ERISA while those trials were completing their interpretation and analysis. She went on ERISA, and within a week, her symptoms were gone. She no longer had fevers. She no longer had abdominal pain. And within a month, she had a near CR in her liver. And within 2 months, she had complete eradication of her disease. And what's interesting about her is she has stayed disease-free now for almost 5 years, with no evidence of any kind of progression.
That's somewhat unusual in terms of responders.
It's unbelievable. I mean, it
certainly was exceptional for any lung cancer patient with metastatic disease. But in your experience since then, have you seen many patients who've had clearance of disease like this for long periods of time?
So what we found is in the mutation-positive patients, we find about a third have experiences like she did, where you see remarkable
Very
clearance
prolonged.
of tumor and prolonged benefit. Another group of patients have remarkable shrinkage, but they develop resistance relatively quickly, meaning within a year.
Yeah. Okay, so now these observations were quite unique and somewhat unexpected, but when did the idea occur to you and to your colleagues in the laboratory that there might be an underlying difference between those patients that really remarkably responded and the ones that did not?
So the way that the mutation story was evolved, and the mutations were worked on really at 3 principal places: at Mass General in the laboratory of Dr. Daniel Haber, at Memorial Sloan Kettering in the laboratory of Harold Varmus and William Powell, and at Dana-Farber in the laboratory of Matt Meyerson. And at the MGH, the approach that led us to think that this might be a particular mutation issue was that we had seen these remarkable responses. And I remember one day, my patient, the patient I just described to you, had her story on the front page of the Boston Globe.
Yes.
They talked about what a remarkable response it was. And Daniel Haber, who you and I both
Reads
work
the
with,
paper.
and he reads the paper. Daniel's reading the paper, and he made the connection that these patients must have mutations
different
in the EGFR gene.
Had you thought about the fact that their clinical presentation was actually different, that these were non-smokers, these were younger women?
So that was a feature of all the patients who had the great responses. But the issue of mutations had been addressed within the lung cancer community, and most people felt that they couldn't be happening because they were too rare. And there had been some people who had screened for mutations in the EGFR gene, and it just was felt to be too rare an event to explain what we were seeing. Daniel came at it from the perspective of having had a long career in the genetics of breast cancer and Wilms tumor, and had been thinking a lot about what made GIST in sarcomas different and what made CML different as well, and thinking about how those genetic events describe responsiveness to the kinase inhibitors.
So the idea that they're activating mutations underlying response, that was the hypothesis at least. And then actually doing those studies, it took a remarkably short period of time to actually get the evidence, the early evidence together that led to the papers. Maybe you can tell us a little bit about that experience.
The day after the newspaper article came out, Daniel called me up and he said, "Tom," he said, "I'm pretty sure that your patient has a mutation in the tyrosine kinase domain of the epidermal growth factor receptor.
Yeah.
I said, Daniel, I said, how do we go about proving that? He said, send me some samples. So we went back to patients who were enrolled in, we have a very large, as you know well, and we're instrumental in supporting, we have a very large molecular epidemiology effort at the Mass General. And we had blocks and samples on a wide number of patients who were participating in our lung cancer trials. So we rounded up 10 samples of patients who had these dramatic responses, like the woman I just described, sent them to Daniel, and his lab found that there were 8 of the 9 patients that he had that were that he could analyze had EGFR tyrosine kinase domain mutations.
Yes, and then they were actually able to look at a large number of other patients that didn't respond and found that very few of them or none of them had it.
Right, and then we looked at the non-responders and did not find mutations in the non-responders. Since then, there have been, as I mentioned, the Dana-Farber group, the Memorial group, actually the group at Vanderbilt found them. In fact, what's interesting is the initial description of EGFR mutations was actually found in David Carbone's lab in Vanderbilt, and David described it as a potential resistance mutation to gefitinib. And that was a very interesting finding. He published that he presented it at AACR before our lab, our group had felt that it was possibly an activating mutation that was responsible for the malignant phenotype.
So it was actually shown subsequently in cell lines that if you put in these mutations, if you produce cell lines that carried these same mutations, they were actually activating, and that they were super sensitive to EGF stimulation and to inhibition by EGFR receptors, or inhibitors. So actually it was nicely demonstrated in model systems that these kinds of mutations could produce a substantially greater sensitivity to inhibitors. And that was actually a part of the initial papers.
And that's the work that Jeff Settleman contributed, and his great contribution to this field has been describing the physiology of what an EGFR mutation does, and the preferential signaling that you get, and the growth advantage that having a mutated EGFR gene gives a cell.
One of the other aspects of this that I've always been intrigued by was the finding in the paper from the Dana-Farber that so many of the Oriental patients with lung cancer have the same kind of mutation and sensitivity to RESA. And it sort of brought to mind the idea that maybe there's a different epidemiology behind this disease. Maybe there's a different environmental exposure. Maybe there's a different genetic basis of this. Now, do we understand this at all at this point?
So since our observations, groups in Japan and Korea have done fabulous work looking at the epidemiology of EGFR mutated lung cancer. In Japan, 20% of lung cancer in men is due to EGFR mutations, and 85% of lung cancer in women is due to EGFR mutations. So it's an enormously common problem in the Japanese population. Dr. Mitsudomi has done fabulous work looking at and confirming the importance of EGFR gene mutations in driving the pathology. Now, what we don't know is why do Japanese patients get EGFR mutations more often?
Yes.
We know that they're, as you pointed out earlier, they're associated with non-smoking, they're associated with women, adenocarcinoma. They're almost never seen in squamous cell. In fact, I think there's 1 or 2 cases in the literature in squamous cell.
Do we see this also in Asian Americans?
Yes. So it's also seen in Asian Americans.
So that suggests that it's really not environmental. It's probably genetic.
There's almost certainly a genetic component. We know they're not germline mutations, with very rare exceptions. There have been 2 or 3 families where EGFR germline mutations have been described, and Daniel Haber's lab described one of those families with a germline EGFR mutation. But in my mind, what must be true is that there must be some polymorphisms in the way environmental substances are metabolized or interact with the gene, with the genetic environment to create an environment where mutations occur.
So before we go on with the more recent trials, Mario, can you tell us more about the role of EGF in the normal epithelium, the health of the normal epithelium?
As Tom has described in lung cancer, the epidermal growth factor receptor also plays a critical role in the proliferation and the survival of epidermal cells. As seen in this slide, the immunohistochemical staining shown positively for abundant expression in brown for the epidermal growth factor receptor in keratinocytes, as well as around the hair follicles.
I'd like to turn to the side effects of treatment. There is no free lunch in oncology. There never is. And we began to notice that patients were quite bothered by the rash that developed. At the same time, development of rash was a sign of more likelihood of response. I guess this has been borne out. Can you tell us a bit about this problem, Mario, and what you've done to address it?
Yes, Bruce. Indeed, about 75 to 90% of patients that take these EGFR inhibitors for a variety of tumors will develop some degree of a papulopustular rash that frequently affects the face and upper body and leads to significant decreases in terms of quality of life, a thing that we have frequently measured in these patients. What is perhaps the greatest irony, as you say, is that patients that have a worse rash tend to have a better survival. And this also has been demonstrated across all tumors with most of these agents. In particular, in lung cancer patients, with the use of Tarceva or Erlotinib, the progression-free survival has been increased by about fourfold in patients that have a severe rash when you compare them to patients that do not develop a rash.
But don't you think part of it is that the ability to develop a rash might indicate an intact immune system or a immune surveillance that somehow is more
good point.
intact? Or
that's a great point, and in fact, in this paper, it was shown that people with a better performance status developed a worse rash to support that point. And it takes us to the point where when Erlotinib was first tested about 20 years ago in Europe, in which it was given to healthy young volunteers, and the rash was so severe they thought the drug would never make it to the market.
I suppose that means to the pharmacologist that it's a sort of a pharmacodynamic indicator, a biomarker of adequate drug levels. If you get enough drug, and we know there's a lot of variation in the pharmacokinetics of these drugs from one patient to the next. Cigarette smoking affects the rate of elimination, for example. The more drug you get, the more effective drug exposure you get, the greater the chance of rash and the greater the chance of response. So it all makes sense. But how do you deal with this rash then?
So the important part about dealing with the rash, I think, because we believe that the underlying pathogenic effect is apoptosis of keratinocytes in the skin due to disruption of EGFR signaling, is to control the inflammation that results as a consequence of those dead or apoptotic keratinocytes. And the best way to go about it is with the use of topical formulations, such as topical steroids that minimize that inflammation, or topical or oral tetracycline antibiotics, which also exert a strong anti-inflammatory activity. Tetracycline-like drugs are indicated in the early stages. In fact, the only 2 randomized studies that have been published have used tetracycline antibiotics as a prophylactic agent, so within the first day of starting these EGFR inhibitors.
Is it routine to start doxycycline or a similar agent right in the beginning as you're using Iressa or Tarceva?
In our practice at Northwestern, we offer every patient the possibility of being treated within the first month with a tetracycline antibiotic, because we know that 90% of these patients will develop the rash, so the likelihood is that they will develop it. So we treat them for 1 month, and then we stop it and we reassess whether they have the rash.
Is it important to protect sun-exposed areas?
Yes, that is also critical, because keratinocytes or epidermal cells will also be more susceptible to the damaging effects of UV radiation when their EGFR pathway is inhibited. So the tetracycline antibiotics have shown benefits in other skin diseases in which infection does not play a major role, such as acne and rosacea. In fact, so far there are 2 randomized trials that have shown benefit of minocycline in patients treated with cetuximab, a paper published in the Journal of Clinical Oncology last year by a group at Memorial Sloan Kettering. And the NCCTG also has a randomized trial showing that tetracycline, 500 milligrams twice daily, minimize the incidence of severe rash in patients treated with a variety of these agents.
So, Mario, tell us about the sequence of changes that occurs as one uses an EGFR inhibitor.
Initially, within the first few days of administration of these drugs, patients will develop a sensation of sunburn, redness, and swelling of the central face. This will be followed by the formation of papules and pustules, which are associated with burning and tenderness in about 62 to 73% of patients. This figure illustrates the chronological order of what most patients will experience with the use of EGFR inhibitors. You can see that within the first 2 to 4 weeks, patients will develop the papulopustular or acne-like rash. This will be followed, once the rash subsides, with post-inflammatory changes, such as dark areas in the skin in areas previously affected by inflammation. At about the 6th week, patients will develop dry skin or cirrhosis, which is a consequence of abnormal keratinocyte migration and maturation, which in the fingertips may be manifest by fissures or fissura in the fingertips. In addition, after the 8th or 12th week, patients will develop these tender areas around the fingernails, or paronychia.
And Mario, the paronychia, is that seen as commonly with the monoclonal antibodies as is with the tyrosine kinase inhibitors?
It is very interesting because patients that have been followed prospectively in Spain have found that with the low molecular weight agents, paronychia is seen more frequently with low molecular weight agents than with monoclonal antibodies.
Yeah.
And it tends to occur over a long period of time after about 3 months.
What about the most extreme cases? What do they look like, and can it ever really require either changing the dose or stopping treatment?
Well, the severe cases are characterized by very tender or pruritic lesions affecting the face and upper chest, and these lesions do require, in the majority of cases, for the dose of the EGFR inhibitor to be modified.
Mm-hmm. They're really an index of how much drug is actually getting into the skin and what its effectiveness is, so that by modifying the dose, you'd hope that the same thing would be true of the tumor, that you would still have an effective dose of drug as compared to other patients if you lowered it to the point where this rash went, at least was under better control. Yeah. Is it ever necessary to really stop treatment in patients because of the skin toxicity?
I believe that with close observation and frequent follow-up of these patients, one does not really need to interrupt completely the use of these agents if it is not for a type 1 hypersensitivity reaction, which is more common with the monoclonals.
Tom, what's your experience in this regard? Do you ever actually have to stop treatment?
I do. And what I usually do is I'll stop treatment and then resume about a week or two later at a slightly lower dose. Probably about 5% of the time I'll have to do that. Usually it's for this type of reaction that Dr. LaContour is pointing out, but occasionally even I had to do it for paronychia, for people with severe infected paronychia. You give them a break and give them antibiotics, give them some Keflex while the nail changes resolve, and then you can resume dose, usually at a lower dose.
Is this more of a problem with Erbitux than it is with the small molecules?
The papulopustular rash?
Yeah.
I think it is more severe and it is more difficult to treat with the monoclonal antibodies, yes.
And is the same thing done there, dose modification or stopping? Or,
if it's severe, yes. Yeah. But I would say, in general, we find ways, particularly when you partner with a dermatologist such as Mario, you find ways to manage these that allow patients to stay on treatment because most of our patients don't want to stop drug.
Yeah, right. I mean, particularly in patients that are getting benefit from it, either not progressing or responding.
Yeah.
And are there specific treatments for each phase of the disease?
Yes, there are specific treatments for each phase of the disease. Therefore, it is important to keep in mind this sequence of events, as one would want to use an anti-inflammatory agent in the early stage, and an emollient or a moisturizer in the middle stages where you have the dry skin, and then you would have to use antibacterial agents for the paronychia that you can see on the right. On the right aspect of the slide. Yeah.
Are there differences, Mario, in terms of the degree of rash and the type of rash between or among the various agents that inhibit the EGF receptor?
Yes. The rash tends to be more frequent, as shown in this slide in the left panels, with the use of monoclonal antibodies occurring in about 90% of patients overall, and in those patients, about 17% being grade 3, when compared to the rash that occurs with the use of small molecules like Erlotinib and Lapatinib, as seen on the right panels, in which the rash occurs in about 75% of patients overall and tends to be grade 3 in a much lesser extent, in about 9 to 7%.
One question I have, Mario, the issue about survival in cetuximab, is it also the same as it is with Erbitux and Tarceva in terms of rash being related to survival?
Yes, it has been shown in colorectal cancer patients, in head and neck squamous cell carcinoma patients, and in pancreatic cancer patients. Also was demonstrated in a study published by OSI last year.
So back to the therapeutic trials, Tom. Now things have really progressed a good deal beyond these initial studies that showed these 10–15% of patients dramatically responding. This led to some very nice trials in which patients were selected based on the presence of mutation to see whether there would be a really high response rate up front. Can you tell us the early results of those trials?
So we think that when you look in North America, about 13% of lung cancer patients will have EGFR mutations. So our group, led by Alicia Sequist, went ahead and did a trial, multi-center trial in North America, looking at identifying metastatic lung cancer patients up front who had EGFR mutations and treating them with gefitinib. And that trial will hopefully be published within the next month or so in the Journal of Clinical Oncology. And that trial showed that more than half the patients had partial responses. The time to progression was nearly a year. And these kind of results are unheard of in lung cancer. And our group is not the only group to do that. Rafael Rosel's group in Spain has shown even better results in frontline therapy, and Dr. Mitsudomi and other groups in Japan have also shown if you treat patients up front, you get more dramatic benefits.
Right. Do we know is the natural history of this subset of patients any different than that of the other patients who are excluded from trials? That is, do they have a slower time to progression, a different natural history?
Absolutely. So we do believe that not only are mutations a predictive factor for response or benefit from EGFR tyrosine kinase inhibitors, but as pointed out so nicely by Francis Shepard, they're also a prognostic factor. We do know that underlying that these patients do have a better survival than patients who have a more typical smoker's lung cancer. Now, whether that could be impacted by the fact that they occur in non-smokers, and non-smokers have, by definition, they're younger, they tend to be healthier, they don't have as much coronary or underlying pulmonary disease, that might explain some of it.
So this study suggests that if you have a young patient with a history, not smoking, particularly a female, that you should test for a mutation, and if you find it, employ this as your primary therapy.
I think there's no doubt that EGFR mutation testing has its greatest advantage in the setting of selecting first-line therapy in patients. And what I do in my practice is patients who are never smokers or light smokers or Asian women. Those are the patients I test routinely. I haven't been doing mutation testing for choosing second-line or third-line agents because I'm not entirely certain it tells us that much.
So do these drugs have value as second-line agents?
Yes, and so the FDA has approved Erlotinib in second-line therapy of lung cancer. Gefitinib is approved in Asia and other parts of the world where it has activity as well. In fact, there was a large study at the ISLC meeting in Seoul just this past September that showed that gefitinib was equivalent to docetaxel in second-line therapy of lung cancer. I think as you and I were speaking of just before this program, yes, there are the patients who have the dramatic responses, and that's important. But for a larger group of patients, they have a modest benefit, and that's still important in lung cancer. Being able to make people live longer, even if it's just a few months, we think is important. And these drugs do give a modest benefit to a large number of people. Now, how you predict who those patients are is a little more difficult. Is it FISH copy number? The group at Colorado and the group in Canada have very nicely suggested that if you look at increased copy number of genes by FISH, you might predict which patients have the prolonged survival.
What about smoking? Is that a negative factor? I've heard that.
So smoking is a problem all around in terms of it changes. You pointed out earlier, I think it changes the pharmacology of the drugs. It changes the ability of the drug patients to get good drug levels. And smokers tend to have worse outcomes. However, when one looks at the subsets of the BR21 study, which is the Canadian study that looked at Tarceva versus placebo, even in smokers, there probably still is some benefit.
Some benefit, yeah.
And to follow up that point, Bruce, it's important to note from the BR21 trial that smokers also develop less severe rash, perhaps because of the effects on decreasing
lower drug levels.
And one question I have is, and I have several patients who've been on these drugs for 2 years, 3 years, and it seems to me that the cutaneous manifestations burn out over time. Why is that?
I think that's a very interesting point, because I think that the skin has a very a high plasticity or ability to withstand that negative effect of EGFR inhibition. And in a similar way that one would develop a callus in an area of frequent trauma in the skin, I think the skin becomes accustomed to the constant inhibition of this receptor and somehow overcomes this pathway inhibition and is able to function normally.
There are probably adaptive pathways that we don't know or we don't understand at this point, right?
Exactly.
So what do you think the next step for these drugs might be? Is there a possibility that we would be giving this as adjuvant therapy in earlier lung cancer and in people that are EGFR mutation?
So I'd say, Bruce, two things. One is absolutely adjuvant therapy makes sense. We have a large trial that we're doing, and Memorial Sloan Kettering is also doing a trial where we're going to be giving adjuvant Erlotinib to patients who have mutated lung cancer for a 18-month to 2-year period. Managing rash in those patients will be particularly important as we go forward, since getting someone to commit to a 2-year trial drug, I think, will be critical. I also think that where these drugs are going is toward combination therapy. I like to think about the way we treat tuberculosis, we don't use one drug. The way we treat Hodgkin's disease, we don't use one drug.
There are very few exceptions to that.
Very few exceptions to that point. Yes. And I think that the current way we treat cancer now of sequential single agents, I think will have to give way to targeted agents given together. And finding, in mutated lung cancer, a 3 or 4 drug cocktail for EGFR mutated lung cancer, I don't think it's crazy to think that one day we may get, if not cures, profound prolongation of survival when we start doing that.
Tom, let's summarize what we know about resistance to these small molecules that inhibit EGFR.
I think one of the great advantages of sequencing and looking for the genetic changes that we have a much better window into what accounts for resistance. And I think ultimately we'll be treating patients with combinations of drugs that might overcome that resistance. Now we know that T790M, a secondary mutation in the EGFR receptor, is an important resistance mechanism. We know that amplification of c-Met in a very important paper that was reported by Dr. Jeff Engelman from our institution and Dr. Passiani from the Dana-Farber this past year, where c-Met amplification was found to be important as a mechanism of resistance. And there are undoubtedly other mechanisms of resistance that we haven't yet described, but between those first two, we think we have about 60 to 70% of the resistance mechanisms that might be clinically relevant.
So there's a significant fraction that's still not understood well. And
Absolutely.
It could involve all sorts of changes, epigenetic changes or changes in other pathways that substitute for EGFR signaling.
Absolutely.
Yeah, or apoptosis as well. So all of this introduces the possibility of multiple different kinds of combination therapies for lung cancer.
Yes, and I think ultimately when you think about what the therapy of EGFR mutated lung cancer might be like in 5 to 10 years, I would hope that we would have a drug which gets the EGFR tyrosine kinase that also inhibits T790M. You combine that with a drug that might get c-Met. You might also think about adding an angiogenesis inhibitor, either a monoclonal antibody like bevacizumab or a small molecule that might be able to do that. And then you think about other drugs that might approach these other mechanisms that we haven't yet defined.
Right.
But I think the idea that one drug is going to cure a complex disease like lung cancer is unlikely. But 4 or 5 might, and we know that from lymphoma, we know that from Hodgkin's disease.
I think your discussion also introduces the idea that we may have to profile these patients in terms of their molecular features of the tumor in order to select the right combination.
And that profiling, I think, becomes more and more and more important, particularly as you go through therapy. Now, as you and I have been speaking of a lot, one of the things that's allowed us to do profiling now has been some of the projects we've been doing at Mass General looking at circulating tumor cells in Dr. Mehmet Toner and Dr. Daniel Haber's lab, where they've been able to, using a microfluidic chip, isolate rare circulating tumor cells and actually molecularly profile those. So the ability to go back in a patient with lung cancer and actually get tumor cells that you can profile.
I think one of the things it's important to point out with these studies is that the tumor cells are in fact not so rare, that there are hundreds, if not in some patients thousands, that almost all patients with metastatic disease have these cells, and you can get at them by just sampling the blood, which is, I think, going to revolutionize the way we approach diagnosis and selection of therapy, and maybe even monitoring response. So now that these small molecule inhibitors of EGFR and even the monoclonal antibody are going to be commonly used in treating lung cancer. What tools are available, Mario, for helping the medical oncologist deal with the issue of side effects, and particularly the skin?
Well, Bruce, there are tools that are easily available for oncologists in order to mitigate these side effects. In the May 2007 issue of The Oncologist, an expert international panel convened and resulted in a management algorithm for the treatment of this rash. And this can be obtained free of charge at theoncologist.com in the home website by clicking on the link and downloading a PDF file, or it can even be mailed to oncology offices. And one can receive things such as the paper that contains all the management algorithms and background and what is really underlying the pathogenesis of this rash. In addition, other important tools such as a patient pamphlet that educates people as to what side effects may be occurring so that they are able to recognize these side effects and call the oncologist's office so they can receive appropriate treatment. And another result of this international panel that was directed by Tom is the development of this poster that can be conveniently located in the oncologist's office and easily delineates the treatment algorithms for each grade of developing rash. For example, we know that when the rash is mild, we would recommend to treat with only a topical agent, and when it's moderate to severe, we add other agents, such as oral tetracycline antibiotics or oral steroids.
Mm-hmm. Well, that's very helpful. Mario, is this an exception in terms of what you find with targeted agents, or do you think that the problem of skin reactions is going to be a consistent effect of these drugs?
I think that the appearance of these dermatological side effects will only increase as these new agents are introduced. As Tom mentioned, the use of dual agents targeting EGFR as well as HER2 has also resulted in dermatologic side effects. For example, we know that with Lapatinib, which is the dual inhibitor, we do see dermatologic side effects, although they are not as severe.
Yeah.
With other multi-targeted kinase inhibitors, the dual inhibitors of VEGFR, PDGFR, beta, and RAF, such as Sorafenib, and also Sunitinib, we do see a lot of dermatologic side effects, but they are very different. We see more of the hand-foot skin reaction, which is characterized by these tender blisters on the palms and soles.
We briefly talked about the hand-foot syndrome that develops with some of the targeted agents. Can you show us some examples of this?
So in these photographs, we can see the characteristic hand-foot skin reaction occurring to multi-kinase inhibitors. In this case, a patient treated with Sorafenib for hepatocellular carcinoma developed these tender blister-like lesions on the flexural areas of the palms and on the areas of pressure in the soles as well. But we can see how another patient treated with Sunitinib also developed these lesions, which after 2 weeks of treatment with the vitamin A analog Tazarotene and the keratolytic urea resulted in a marked improvement in the tenderness as well as the appearance of these lesions.
Their management would be different than the management of the acne-like eruptions that we see with EGFR receptor inhibitors.
Exactly. The management is different to that rash, and in fact it's different than the management we would do for hand-foot syndrome to conventional chemotherapeutic agents like doxorubicin, for example.
Can you give us a reference to a good guide for how to manage hand-foot syndrome, for example?
The hand-foot skin reaction could be managed with the use of topical agents, and that is a publication that should be coming in an upcoming issue of The Oncologist this summer.
Terrific. Okay. Well, I'd like to conclude this discussion by saying that this whole experience with the EGFR inhibitors in lung cancer really serves as an example of how the field is moving toward identifying patients who in subsets of major diseases who have lesions, molecular lesions, which predispose them to respond. I think that's the direction that we'll be going in the next few years in order to optimize the therapy with this whole class of drugs. Fortunately for the EGFR receptor inhibitors, we're beginning to understand what those molecular changes are and identify the patients who are particularly likely to benefit. We don't have that kind of knowledge for many of the other drugs, but I think we're moving in that direction, and I think that's clearly how we're going to benefit our patients. It's not only identifying new drugs, but finding the particularly responsive patients to treat. And I think, Tom, your group and others in the lung cancer field have really set a major pattern of understanding for us that will be emulated in other kinds of tumors.
The Society is proud to host this milestone in oncology, and we are especially grateful to our honored guests, Dr. Lynch and Dr. Lacouture, and our host, Dr. Chabner, for their discussion that harbors new hope for lung cancer patients. We are also thankful to our benefactors for their unrestricted grant support, and to the peer-reviewed journal, The Oncologist, in whose association these programs are produced. Thank you.